Yeah, good evening. Today my topic is on maxillofacial trauma imaging. First, we will see the CT techniques. The facial CT scan should not be an extended brain CT technique. In the facial CT, the aim of imaging is to detect the fracture lines and to look for any soft tissue injuries, especially in the orbit, and to search for any intracranial complications associated with the facial trauma. The techniques are: the patient has to be positioned in supine, and the patient positioning must be symmetrical. The FOV we use in the facial CT is a smaller one, which is of 19 centimeter, and the scanning technique is perpendicular to the hot plate. The scanning is from the frontal sinus to the mandible anterocraniocaudally, and anteroposteriorly from the nose to the mandibular condyles. We use a thinner collimation of 1 mm for the bone algorithm and 2 mm for the soft tissue algorithm. The use of the multi-slice scanner, we can do the coronal and the sagittal reformats, which are most useful to detect the subtle and non-displaced fractures in the face. Again, these 3D volume render reformats are very useful both for the radiologist and for the surgeon for the surgical planning. We'll have a short look on the maxillofacial axial anatomy. We'll go from below to above. The lower cuts, this is the hot palate, this is the root of the maxillary sinus, the ramus of the mandible, the small dot is the styloid process, and this is the cervical spine. Going above, this is the maxillary antrum, and this is the anterior wall of the maxillary antrum, the posterior wall of the maxillary antrum, and this is the pterygoid plate, the medial one medial pterygoid, the lateral is the lateral pterygoid plate. This is the nasal fossa. This is the nasal septum. What you see laterally is the zygomatic arch. This is the mandibular condyle, which articulates with the temporal fossa. This is the temporomandibular joint. Going above, this is the ethmoid asile, and this is sphenoid sinus. Anteriorly, we have the nasal bones, both right and the left. And still above, this is the frontal sinus. In this case, you can see a small osteoma in the frontal sinus. The coronal images are very useful to evaluate the pterygoid plates, the hot palate, the orbital roof, orbital floor, and the floor of the anterocranial fossa. As I already mentioned, the 3D reformatted images are more useful for our reporting. And this mandibular anatomy, there are 7 anatomical regions where the fractures can take place. This is the alveolar margin of the mandible. Anterior is the symphysis in the parasymphysis region. Just behind is the body of the mandible containing the mandibular foramen. Beneath is the angle of the mandible. Just above is the ramus of the mandible. Anteriorly, the projecting structure is the coronoid process. The posterior one is the mandibular condyle, which has 3 parts: head, neck, and subcondylar region. In face, we have 4 transverse and 4 vertical buttresses. Buttresses, the word means in the face there is an increased cortical bone thickness. All these buttresses act as a supportive structure for the functional unit of the face, like muscles, eyes, dental occlusion, and airways, to maintain the optimal relationship between each other and define the form of the face. First, we will see the 4 transverse buttresses. The one above is the superior one along the floor of the orbit, that is the upper transverse maxillary buttress, floor of the orbit, and the second one along the transverse buttress is the lower transverse maxillary buttress along the alveolar margin of the maxilla. The third one is along the alveolar margin of the mandible, that is called as the upper transverse mandibular buttress. The lower one is the lower transverse mandibular buttress along the lower margin of the mandible. This is in the transverse location. And again in the face, we have 4 vertical buttresses. That is the medial maxillary buttress along the medial margin of the orbit and along the anterolateral wall of the nasal fossa, which is marked in red color here. The one lateral is the lateral maxillary buttress along the lateral wall of the orbit and along the anterior margin of the maxillary sinus. The one behind is the posterior maxillary buttress, that is in the pterygomaxillary fossa. This contributes to the pterygoid, this fracture causes the pterygoid plate fracture. So the last one is the fourth vertical is along the posterior margin of the mandible. These are all the supporting structures. When these supporting structures undergo undue force, they can cause fracture and resulting in complications. So the role of imaging is to detect the soft tissue and the bone injuries for characterization and for the surgical planning. As we all know, CT is preferred nowadays over the X-rays, which is giving the more accurate diagnosis, and it's easier to perform in multi-trauma and non-cooperative patients. And if we suspect more than one fracture, like simple nasal fracture is easily clinically diagnosed. If you suspect more than one, then we can go for the CT maxillofacial imaging. So first we'll see the X-ray imaging. The standard X-ray projections, what we have is nearly 5 to 6 views. For the face, we have the anteroposterior AP view, PA view, this is the Caldwell view, the Waters view, Toynes view, and for the base of the skull, we can use optionally. So during the interpretation of the facial X-rays, we have it in mind the two basic lines which is to be noted in the facial X-rays. First is the Dolan's line, which is also called as the elephant head. This is well delineated in the Waters view. The first line is drawn along the margin of the orbit. The second line is along the zygomatic arch. The third line is along the anterior wall of the maxillary sinus. So we have to draw it on both sides. If there is any disruption in the lines, that indicates the bone has fracture. One is the Dolan's line, the other one is the McGregor or the Campbell's line. It has 4 components. The first line is along the superior orbital margin, drawn on both sides. And the second is along the inferior orbital margin, including the zygomatic arch. The third line is along the alveolar margin, and the fourth is the mandibular line. So since the facial X-rays, nearly 1/3 of the X-rays are false negative, we have to rely on the CT. But in CT, we have one artifact called the reconstruction artifact. This arises during the reconstruction process, especially seen in the coronal and the sagittal images. If we know this to eliminate, then we can easily diagnose the fractures. So in face, we have 3 segments. The upper 1/3, that is extending from the forehead to the upper margin, that is the supraorbital margin. This is the upper third of the face, and from the supraorbital margin to the level of the alveolar margin is the middle third, and below which, including the mandible, is the lower third. Most of the fractures occur in the middle face component, and these fractures are associated with the cervical spine fracture and the skull base fractures, especially in association with the Lefort's 2 and 3. So, what is the main aim of this reporting is to help the surgical planning. We have to aim in reporting to remove the bone fragments in the vital areas, especially in the orbit and the bone structures, to reduce the fractures before adhesions, and to release the muscles before fibrosis, especially in the extraocular muscles, and to seal the skull floor defects before the meningitis sets in, and to ensure the patent airways, and to remove the foreign bodies before the infection sets in. This is the main goal of the reporting. So now we'll go for the detailed fracture description. The classification of the fracture in the face goes like this: the simple, complex, transverse facial, and the mandibular fractures. In the simple, we have the orbital wall, sinus wall, nasal bone, and the zygomatic arch fractures. In the complex, we have 1 or 2 bones fracture like the zygomaticomaxillary complex fracture, Naso ethmoidal complex fracture, mesofrontal, mesomaxillary fractures. And in the transverse facial, we have the famous Lefort's fracture. The others are the smash injuries, multiple fractures, unclassified, and the fourth is the mandible fracture. Now we'll go to the imaging approach in the facial CT. In the emergency setting, first we have to look into the airways and the orbit. Once that is clear, then we have to go into the other structures. First we have to see the paranasal sinuses. in the paranasal sinuses, we have to see whether this is clear or it is having some soft tissue opacification. First, if the paranasal sinuses are clear, then the group of fractures which is included in this are the nasal fracture, zygomatic arch fracture, mandibular fracture, and the dento-alveolar fracture. The others we will see later. First, we will see the nasal fracture. Nasal fracture is the most commonest facial injury, as it is the most prominent structure in the face and it is very thinnest structure. The nose has a suture, and the suture line is usually very translucent and it is parallel to the nasal bone. The fracture is usually transverse to that of the nasal bones. Like in this case, it is a comminuted nasal fracture. As such, for the nasal fracture, X-rays are not necessary. Only if we suspect more than one fracture in the face, we can go in for the CT imaging. So the CT imaging and the nasal fracture is helpful in this way. Like we can assess whether the nasal bone fracture is unilateral or bilateral, simple or comminuted. If comminuted, we have to mention whether the fracture fragments are telescoping or depressed. And any associated nasal septal fractures or other zygomaticomaxillary or Naso orbital ethmoidal complex fractures are there. So, usual association of this nasal bone fracture is the nasal septal fracture anteriorly along with nasal hematoma. If the nasal hematoma is promptly identified, we can eliminate the complications. Like epistaxis can arise from this hematoma. And sometimes if the hematoma is large enough, it can compromise the nasal airway. If it is left unattended, the late complications like infection, abscess, and the necrosis of the cartilaginous portion may lead on to the saddle nose deformity. Next comes is the isolated zygomatic arch fracture. As I already mentioned, the Campbell's line has to be properly noted in the X-rays. If there is any discontinuity on compared to the opposite side, then the structure has a fracture. Here is an example of the zygomatic arch fracture. The zygomatic arch fracture is a comminuted one, and in the middle fracture fragment is seen impinging on the coronoid process, and so that the masseter origin is also impinged. So the patient has a restricted mandibular movement called trismus. So the next comes is the mandibular fracture. Since the mandible is the U-shaped structure, whenever the force is given to the fracture, there will be a typical bilateral injury pattern. So we will see the force dynamics. If the patient had force occlusion, there will be a temporomandibular joint dislocation or subluxation or the condylar region fracture. If there is a blow from lateral or the frontolateral region of the mandible, then there will be a fracture of the body or the angle of the mandible. And the fracture often gets displaced because of the traction of the attached muscles. Here in the mandible we have three standard X-ray projections. PA view for the rami and the body of the mandible to be visualized. Toyne's view for the condyle, rami and the temporomandibular joint to be visualized. The lateral or the oblique views for the body and the angle of the mandible for proper imaging. This second one, what I have shown is the panoramic X-ray, and that is not usually available in the emergency setting, but it is more helpful for imaging of the rami, mandibular condyles, and the tooth injuries can be well seen with this X-ray. So this is an example of the mandibular fracture. You can see a small fracture along the alveolar margin of the mandible anteriorly, and there is an associated angle of the mandible fracture. You must always search for the second fracture in case of the mandible fracture. Then next is the Flail Mandible. The displaced mandibular fracture is seen in the region of the symphysis because of the traction of the muscle attached to it, and there is an accessory second fracture, like there is a displaced mandibular ramus fracture along with overriding of the fragments. This leads to the resultant subluxation of the mandibular condyles, and there is an widened temporomandibular joint space. So because of this multiple components, this is called as Flail Mandible. This type of injury can cause airway compromise, like large pharyngeal hematoma, inability to maintain the tongue in the anterior position when the patient is in the supine position. So the immediate surgical intervention is needed for the proper alignment on the proper occlusive, the maxillomandibular occlusion has to be maintained in this patient. Next comes with the alveolar fracture. The alveolar fracture, the most common, we have to see whether this alveolar fracture is associated with the teeth injuries. So if you suspect there is a teeth injury, then if you suspect that in the CT, we can go with the X-rays for confirmation. And if there is a missing teeth and there is a history of possible aspiration, we have to do the chest X-ray to confirm that. Here is an example of the alveolar bone injury with the tooth subluxation from the alveolar fossa. The numbering system goes according to the American Dental Association in the maxilla, from number 1 to 16 on the maxilla and 17 to 32 in the mandible. The root of the tooth is in the alveolar socket, the crown is above it. The tooth injuries may be of dislocation, the complete or the partial avulsion from the alveolar socket. There may be subluxation or there may be fracture. Second, once we have seen whether the paranasal sinuses are clear, we have to think about all the fractures what we have seen earlier. Then, if the paranasal sinuses are having the hemorrhage, that is a soft tissue opacification, then we have to see the pterygoid plates. Pterygoid plates, then we have to see whether the plate is fractured or there is no fracture. First, here we will see the there is no pterygoid plate fracture. Then the components of the fractures are the frontal bone sinus fracture, the naso-orbital ethmoidal fracture, orbital fracture, zygomaticomaxillary complex fracture, and the maxillary fracture. First is the frontal sinus fracture. In the frontal sinus, it has an anterior table, the posterior table, and the floor of the frontal sinus. The anterior table is thicker, and if it is injured, it is more of a cosmetic alignment is needed. But if the posterior table is injured, the dural tear is associated with this fracture, and the CSF leak can occur, and associated brain parenchymal injury is likely. The floor of the frontal sinus, if it is injured, the nasofrontal duct injury has to be suspected in all the cases of the frontal sinus fracture. So the checklist is we have to say whether it is anterior table or the posterior table the frontal sinus is involved, and whether it is comminuted or displaced fracture fragments or seen impinging on the brain parenchyma. And then we have to see the signs of occlusion of the nasofrontal duct. That is, the fracture is seen more medially in the anterior wall, or the floor of the frontal sinus is involved. That has to be given correctly in the report, and the signs of the dural tear like pneumocephalus, all this thing has to be mentioned. Next is the naso-orbital ethmoidal fracture. Here, the fracture involves the nasal bone, the ethmoid bone, and the medial wall of the orbit. So in the X-ray, we will see the haziness of the paranasal sinuses, and better depiction of the fracture lines can be seen in the CT. So as a routine, we have to see whether it is a simple or comminuted fractures. This is an example of the comminuted fracture. If there is a comminuted fracture, there is a collapse of the ethmoid air cells, and these fracture fragments may protrude into the orbit and impinge on the optic nerve. That may cause the optic nerve injury. And this collapse of the ethmoid air cells will give the clinically there will be telecanthus in the face. And the third important thing we have to see is the medial canthal tendon is attached to the medial wall of the orbit, and the purpose of this tendon is slings the globe to the medial orbital wall. Whenever there is a fracture in this, as in this case, If it is a comminuted, then the tendon will pull the fragments laterally, causing the telecanthus. So this has to be mentioned. So the proper repair has to be done for the tendon. So the associations are the orbital fractures, and this may be associated with the Leaford's 2 and 3 fracture. And as I already mentioned, the nasofrontal duct and the nasolacrimal duct are along this process. So the injury is more likely, and the CSF rhinorrhea can take place, and the loss of the vision, frontal sinus fractures or other association of this fracture. Next, coming to the orbital fracture. In the orbital fracture, as I already mentioned, the X-rays or 1/3 gives the false negative. So CT is better for the depiction of the X-rays. Fracture line which is seen better in the CT. The orbital fractures, the wall of the orbit of fracture, this is the case of the medial wall of the orbit, where there is the fracture fragment is seen protruding into the ethmoid air cells. This is an example of the floor of the orbit is fractured. So whenever you see an intraorbital air, then you have to search for the fracture. Subtle and non-displaced fractures like this. This is the non-displaced fracture of the orbital floor. So, as I already mentioned, the retrobulbar or the intraorbital air is indicative of the fracture in the orbit. Next is the blowout fracture. You all know about this fracture. Like if a large object is hitting the orbit and it is not projecting into the orbit, the object may cause the increased intracranial pressure. Because of the increased pressure, there will be a fracture in the orbital floor. Mostly it will be isolated and can associate with the other fractures like mesoorbital and Zygomaticomaxillary complex with the Leaford's fracture. The most important sign which is seen in the X-ray is the teardrop sign. Here you see the air fluid level, and the soft tissue opacity is seen in the orbital floor, giving the appearance of the teardrop. The CT helps to find out whether the bone fragments are seen protruding from the inferior wall of the orbit into the maxillary sinus. Now, the most important thing to be noted in the blowout fracture is the extraocular muscle entrapment. Normally, the extraocular muscles will have the appearance like this. It is a flat. If there is the extraocular muscle entrapment is partial, then it will be a hooked appearance like this. This is an example of the medial wall of the orbit fracture. There is a partial entrapment of the medial rectus. If the muscle appears rounded, then it indicates the whole muscle is entrapped within the defect. This is a case of the inferior rectus muscle entrapment in the blowout fracture. Next comes the globe rupture. The sign what we see is the flat tire sign. This is due to the loss of the intraorbital volume. There is a scleral discontinuity. And the most common associations like intraorbital air and the intraocular foreign bodies are indicative of the globe rupture. The indirect sign for this rupture is lens displacement into the vitreous. Intraocular foreign body, which is better seen in the X-ray itself, and CT is also helpful. This is an intraocular foreign body indicative of the globe rupture. And in the lens injuries, the lens can undergo subluxation or completely dislocate posteriorly, or there may be a fragmentation of the lens. The lens dislocation, as in this case, is not seen because of the hyperdense vitreous hemorrhage. This vitreous hemorrhage and the lens dislocation, along with the retrobulbar emphysema, is indicative of the globe rupture. Next is the retrobulbar hematoma. The retroorbital fat is appearing hazy as in this case. This is due to the retrobulbar hematoma. This will increase the intraocular pressure in the eye, causing the proptosis, and there is a stretched optic nerve as in this case. This hematoma may cause an orbital compartmental syndrome. That is, the increased intraocular pressure may cause the retinal ischemia and there will be loss of vision. This hematoma may be of arterial bleed also that has to be surgically intervened, and this is an emergency position. Next is the ocular detachment. The layers of the ocular globe is getting detached, and there will be the fluid collection. The first is the retinal detachment. The retina gets separated from the choroid, and the vitreous is getting collected in the subretinal space, and this gives the appearance of the V-shaped collection. The apex is at the optic disc, and anteriorly it is at the end of the oris areata. And the choroid detachment is not extending to the optic disc. The collection is suprachoroidal space. The vitreous gets collected, and this gives the appearance of the biconvex lens-shaped collection. Next is the orbital apex fracture. The lateral wall of the orbit is fractured, and when it is extends to the level of the orbital apex, the fracture fragments may impinge on the optic nerve, causing the traumatic optic neuropathy. This is a true emergency. It has to be immediately informed, and the fracture fragment has to be released immediately. Hello? Hello? The checklist for the orbital fracture is, if there is a fracture in the orbit, we have to see, especially if it is in the floor, we have to see whether this fracture is more than 1 centimeter, and there is a chance for the displacement of that is herniation of the orbital contents into the maxillary sinus, and we have to see the signs of the extraocular muscle entrapment, and soft tissue imaging is needed to see the ocular injuries, and we have to search for any associated intracranial injuries if there is an orbital fracture. Next coming is the zygomaticomaxillary complex fracture. This is the second commonest mid-face injury. Previously it is called as the tripod fracture because they have not taken into account of the zygomaticosphenoid fracture, which is not well seen in the X-rays. But now because of the addition of this the zygomaticosphenoid fracture, it is now called as the quadripod or the zygomaticomaxillary complex fracture. In the fracture, the zygoma itself is not getting fractured. The zygoma is just separated from the 4 sutural attachments. Normally, the zygoma is attached to the frontal bone through the zygomaticofrontal suture, and the zygoma is attached to the maxilla through the zygomaticomaxillary suture, and through the zygomatic arch, it is getting attached to the temporal bone, that is the zygomaticotemporal suture, and posteriorly it has a zygomaticosphenoid suture that is seen along the inferior orbital wall and along the posterolateral wall of the maxillary sinus. This zygomaticofrontal is seen along the lateral orbital wall. The zygomaticotemporal is seen along the zygomatic arch, and the zygomaticomaxillary is seen along the anterior wall of the maxillary sinus. So these lines are again helpful in this evaluation. Once there is a discontinuity in the second line, we have to think about the zygomaticomaxillary complex fracture. Here is an example for that. The anterior wall of the maxilla, that is the zygomaticomaxillary suture disruption. The posterior wall of the maxillary sinus, there is a zygomaticosphenoid suture disruption, and the zygomatic arch fracture is that is the zygomaticotemporal suture disruption. And the coronal image, we can see the axial image, we can see the zygomaticofrontal suture disruption that is seen along the lateral wall of the orbit. So in all this component, the infraorbital canal can be injured. So thereby the inferior orbital nerve is injured in most of the complex fracture. This fracture, the most important thing we have to report is the zygoma position. That is, the zygoma, once it gets separated, it has the lambda shaped appearance. this lambda shaped appearance we have to mention whether it is posteriorly displaced, whether it is medially or laterally rotated, and associated orbital fracture we have to mention. We will see how to mention this. See, this is the case of the posterior displacement of the zygoma, and next we will see the medial rotation of the zygoma. See, for this we have to compare the zygomatic injured segment with the opposite normal maxillary antrum. If the zygoma fractured site having the small maxillary antrum, then the fracture, the zygoma has undergone the posterior displacement and it is medially rotated. If the maxillary sinus antrum is wider, as in this case, in comparison with the opposite side, this is lateral rotation of the zygoma. And most of the time it is associated with the orbital floor fracture. Here this 3D volume rendered image is clearly showing the laterally displaced zygoma. So the surgical planning, mainly for the surgeon, the posterior wall, that is the zygomaticosphenoid sutural disruption, whether it is simple or permanent, that is not of much clinical significance, and the zygomatic arch fracture is also not of much significance. The surgeon is mainly oriented towards the anterior wall of the maxillary sinus reconstruction, that is the alignment of the zygoma with the maxillary sinus has to be retained, taken back to the normal position as that of the contralateral side. And if there is an orbital floor fracture, that has to be sealed, otherwise the orbital contents may herniate into the maxillary sinus and causing complications. So the complications of this zygomatic complex fracture is almost out of 4 fracture sites, the 2 is in the orbit. So the orbital contents like globe, optic nerve, extraocular muscle, orbital apex are affected. And if the zygomatic arch is having the comminuted fragment and the fragment is impinging on the mandible, then the patient will be having trismus and the masseter origin will be impinged. Then, as I already mentioned, this fracture will injure the infraorbital canal, and the infraorbital nerve is most commonly injured. Next comes is the maxillary fracture. This isolated maxillary fracture is nothing but the cortical defect in the anterior wall of the maxillary sinus, and there is no associated zygomatic fracture or the pterygoid plate fracture. So the maxillary fracture, the anterior maxillary fracture with the cortical defect and the air fluid level in the lateral maxillary sinus, that is the hemorrhage is seen in the maxillary sinus. Next comes our third imaging approach, is that the paranasal sinuses are having hemorrhage and the pterygoid plates having fracture. Then the famous Leafoot's fracture is included in this group. The Leafoot fracture 1, 2, 3 are in this. Leafoot is a French surgeon. The Leafoot fracture, there are 3 types. In all these fractures, 90 to 100% of the fracture will have the pterygoid plate fracture. If there is no pterygoid plate fracture, that rules out the Leafoot's fracture. The points to be noted in reporting of this Leafoot's fracture are, in the type 1, we have to mainly focus and see the anterolateral margin of the nasal fossa, and to report the Leafoot's 2, we have to mainly see the infraorbital margin, and for the type 3, we have to look into the zygomatic arch. These are the points we have to see and mention in the report, especially in the Leafoot's fracture. We will see in detail the Leafoot's type 1, that is having the free floating hard palate, because the transverse fracture line is seen along the inferior maxilla that runs along the maxillary sinus anteriorly and involving the alveolar margin. Associated nasal septum and pterygoid plate fractures are seen. So this is the pterygoid plate fracture. The inferior wall of the maxillary sinus is fractured. This transverse is giving the free floating appearance of the hard palate. Next is the Leafoot's type 2. This is a pyramid shaped fracture line. The name is given according to the fracture line. This fracture line starts from the nasofrontal region and then goes along the medial wall of the orbit, involves the inferior orbital rim, orbital floor, and the anterolateral wall of the maxillary sinus is involved. And in this type, there is a free floating of the midface. See, this is the anterior and the posterior anterior wall of the maxillary sinus is fractured along with the medial orbital floor of the orbit. So this is a Lefort type 2, since it is associated with the pterygoid plate fracture. Third is the craniofacial separation. There is a separation of the facial bones from the skull entirely. The zygoma is separated from the sphenoid bone, and the nasal bones and the ethmoid bones are separated from the frontal bone. So this is in severe form of all the other types of the Leforts. So first they will see the pterygoid plate fracture, and there is a separation of the zygoma from the sphenoid bone, and there is a separation of the nasal and ethmoid bones from the frontal bone. This is the Lefort's type 3. Sorry. In the Lefort's type 3, the surgical planning is mainly oriented towards the anteriorly located fractures, like the anterior wall and the zygoma, and the dental occlusions are taken care to maintain the alignment. Next, we'll see some of the vertical buttresses fracture. The lateral maxillary buttress fracture that's seen along the lateral margin of the orbit. If there is a fracture in this buttress, here is an example for that. This fracture fragment is seen impinging on the orbital globe. So next is an example. The lateral maxillary buttress fracture is seen causing the full thickness tear of the lateral rectus muscle, and this lateral margin of the orbit fracture extending to the superior orbital fissure. Then the cranial nerves are injured. This is the posterior, that is the pterygomaxillary region fracture. This fracture is in this case it is extending to the foramen ovale. The fracture line is faintly seen here. The foramen ovale, so the possibility of the trigeminal V3 injury is more likely. And in the face, usually we won't get a single pattern of the fracture as such. There may be multiple fracture patterns, and may be associated like nasal fracture with the nasal orbital ethmoidal, nasal fracture with the zygomaticomaxillary complex, or the zygomaticomaxillary complex with the orbital fracture, and associated Leforts can be seen. So this is a multiple pattern of the facial fractures. And the other thing is the panfacial injuries. This panfacial means all the upper third, middle third, and the lower third, all thirds have the fracture. So the complication of all this complex fracture is that CSF rhinolia. We have to identify the intrathecal contrast injection and the demonstration of the contrast leakage in the cribriform plate. For the cribriform plate repair, this study is more important. Next is the post-traumatic encephalocele. There is a herniation of the brain content into the ethmoid sinus, which is better delineated with the MRI. So the facial buttresses plays a major role for the face. We must have the idea about the buttresses and associated injuries. First we'll see the vertical buttresses. This is the medial maxillary buttress. This buttress, if it is fractured, there may be associated nasofrontal, nasolacrimal duct obstruction, and there may be CSF leak can occur, and this medial canthal tendon injury is common in this location. Next is the lateral maxillary buttress. If this is injured, the lateral canthal tendon injury can occur. And the posterior maxillary buttress fracture, that is in the pterygomaxillary region, the fracture can cause the carotid artery injury or the caroticocavernous fistula, and the posterior vertical buttress fracture, the temporomandibular joint dislocation can occur. Coming to the horizontal buttresses, the orbital floor fracture is a main complication, like herniation of the orbital contents, and the vision loss is the most common thing. So we have to focus on that mainly. And then the maxillary alveolar margin fracture can cause the tooth avulsion or the tooth fracture. In the mandibular alveolar margin also causes the malocclusion. And the last one is the inferior buttress along the inferior margin of the mandible. If this is involved, the inferior alveolar now exiting along this mandibular canal can be injured. So we'll see the ABC systematic assessment of this maxillofacial trauma imaging. If the X-ray is given, please look into the correct views. There are nearly 5 to 6 views are there in the maxillofacial X-rays. The correct view gives the appropriate fracture finding. If there is a multiple fracture, we can request the CT. And in the X-rays, the alignment, like we must have the idea about this Toland's, McGregor and Campbell's line. We have to see the bilateral symmetric line positioning. If there is a disruption, the bone is fractured. So while checking the bones, we have to see all the upper third, mid third, and the lower third of the face in toto. The assessment of the cartilage and the joints, so we have to see the sutures, especially the zygomatic frontal suture and the temporomandibular joints are to be mentioned clearly in the report. And then the sinuses and the soft tissue imaging, please check for the local soft tissue swelling and the surgical emphysema, especially in the orbit. And in the sinuses, look for the air fluid level in the opaque sinuses. And in the orbit, here the teardrop injuries to be taken care of, especially in the orbital floor imaging. And the foreign bodies such as the glass and the metals has to be mentioned out of the size of the foreign body properly. So to conclude, there are 2 critical areas. First, we have to see is the airways in the orbit, and then to the X-ray we have to see whether it is clear or the soft tissue haziness is seen. Then the CT is mainly useful for multiple fractures, and in the CT we can clearly delineate whether it is a hemorrhage or the clear sinuses. If there is a pre-existing sinus disease, there will be a lobulated mucosal thickening circumferentially, not like a simple air fluid level. And next, once the paranasal sinuses are visualized, next assessment goes to the pterygoid plate. If it is fractured, then it is a fully foots. If it is not fractured, other group has to be assessed. So this helps in the pattern recognition. So please try to fit all the fractures into one pattern if possible in the conclusion of the report. These are my references. Thank you.